Good morning to people from, I guess, attendees from Korea, and then good evening for American attendees. Thank you for joining my talk. So I'll briefly summarize some of my work related to um, autonomous robotic surgery work, and which is based on a novel what we call 4D imaging system, which is a 3D video imaging system that's enhanced by AI network. Um, as Hyunchar mentioned, so I'm with the electrical and computer engineering, and I also have a joint appointment in dermatology. All right. So so if you think about technology evolution in terms of automobile or transportation, we went from dune buggies to now a autonomous taxi that's operating in certain cities in the United States that has all these different sensors, and then also a neural network that's trained by various different types of AI system that they can basically drive people, place to places. But in terms of surgical devices, it actually there has not been that much um, improvements in the past 150 years. And if you look at the basic surgical tools that use in microsurgeries, they're very similar. Similar cutters, similar a forceps, and similar picks and things like that. So what we like to be able to do is actually utilize some of the technology that actually has been developed, and then also utilize and kind of same I guess roadmap for advanced transportation system, but utilize that on a surgical robots to make the robot autonomous, make the robot, if make it better. But in order to do that, there are some of the key components, and one of the key components is the robot is obviously the sensors. Imaging system is a key element of the robotic surgery, but and also it requires a not only one, it actually requires a multiple. And in addition to it, there has to be a lot of signal processing to be able to get the information you need to in order to control the robots correctly. And but the one of the limitation when it comes down to it, the bottleneck is actually electronics. Electronics, I know it's getting faster and faster and things like that. But if you're trying to do a real-time 4D imaging, just a raw imaging 4D, assuming that we have the capability to do high resolution 4D imaging, this real-time visualization, and an assess tissue instrument interaction and doing intraoperative assessment to make the robot move precisely and then also respond to a tissue response, and then also have various different types of quantitative monitoring. You actually need in the orders of hundreds of gigabits per second of type of processing speed. Okay. So you're really pushing the limit of, what you could do with your computers. Okay. However, if you train the system using AI, and you know what the tissue looks like, and you kind of have an idea of, what to expect in certain cases. What you could do is you can combine imaging with the AI to reduce the required bandwidth in terms of hundreds of megabits per second. Okay. And of course, AI could also do additional things like automated segmentation, predictive modeling to guide surgery, assist surgeon decision making, and standardized training. So whether you have experienced surgeons or novice surgeons, the outcome will be similar. And then you could also use this as a skill assessment and also optimize procedures and then movement. And then at the end of the day, what you would like to do is actually be able to produce surgical outcome that's safe and consistent from time to time. Okay. So, I mean, do we really need to automate robotic surgery? There is a Da Vinci robot, which is being sold well all over the world. But I could tell you working with the intuitive surgical system that makes Da Vinci robots. They are very interested in going autonomous robot. Um, First of all, the reason for it is, first of all, there are 232 million surgical procedures performed per year worldwide. So there are many surgeries being done. And the problem is that the variability in skill set between the surgeons depends on the regional, aspect, are great. Because, the surgery itself depends heavily on experience, skill, mental, and physical state of operating surgeons, or also the training and so on and so forth. And then intuitive surgical systems, Da Vinci robot, it's a state of art, but it uses a teleoperated robotic surgery. So it's still manually controlling the slave arm. Um, and you know, so it actually increased the, a number of minimum invasive surgeries that's done compared to open surgery, but it really has not reduced complicated rates. One of the selling point for Da Vinci robot in the beginning was that, it's a safe and then it could perform surgeries better. And then, in fact, actually, at some point, it actually was true. But it turns out the reason that it was performing surgery better was of people who were able to buy those Da Vinci robot were big, renowned hospitals. So they actually, in a way, they had a better surgeon to operate those Da Vinci robot. Now, as the Da Vinci robot becomes more ubiquitous and everybody's using it, and then when they do statistics, the output between Da Vinci robot and just manual surgery, there was no difference. Actually, in fact, one of the studies that was done in Hopkins compare that with open surgery, and it turns out that open surgery provide better outcome, and then less complications. So, who knows? So we worked with various different types of robot, and I'll just highlight some of the things. And one of the robots that we worked on is called Smart Tissue Autonomous Robot. It's called Star Robot. This project actually started with at Children's National Hospital in DC. The director of this center this was Peter Kim. He was a Korean American. He's at Brown University now, and he started a company. But anyway, and some of the members there actually. So I still used to work with him, and then when he left there, part of this actually came to Hopkins, and then we had now separate projects. Okay. So it actually has a two arm, one arm for suturing, another arm for imaging, and providing all the sensory information for a autonomous suturing. Okay. So why not autonomous? So actually, anatomous, anastomosis, Thomasis. Um, the reason actually we decide to do this one is because it's a necessary and critical part of all reconstructive surgery. There are actually two different anastomosis that they will focus on. One is a larger organs like intestines and things like that, but also we also have a focus work on microvascular anastomosis, very delicate, small lumen suturing. But anyway, so there are over 1 million gastrointestinal, urological, and gynecological type of procedures done in the United States only. So there's a lot of procedures that are done. And you think that suturing, like colon and things like that will be pretty straightforward, but there are a lot of surprisingly significant complications exist. There are clinical leaks, latent strictures, and adhesions that causes a big problem. And then if you look at the complication rate itself, it's like 30% for multivisceral transplantation anastomosis, 19% for colorectal anastomosis, and 1 or 2% for cardiovascular anastomosis. So the complication rate is actually very high. So, um, So we built a 4D imaging system based on structured light imaging system. So we built the older one that's actually a little more complicated, and then required two separate arms, and then require multiple exposures. And then now we have something simple, well, we were able to make it simple because we combine with the neural network. Okay, so typically for this type of a 4D imaging system, we require like 16 shots to make a one 3D imaging. Uh, Basically, like four different frequencies and four different phases. I mean, I guess we can get away with a 3 by 3, which is three different frequencies and three. Okay, now, but by utilizing dual neural network, we only need a single fringe and any phase, and then we can produce a very highly accurate 3D imaging, what we call point clouds, that allows robot to guide within the point clouds. Okay. And so I won't go into details, but we do develop different types of specialized neural networks. So whether CNN and UNet type of a network, and then we optimize and then train procedures so that we could provide a correct point clouds for robotic guidance. Okay, so this is just kind of example of, so this is just the raw 3D imaging you use without AI, and then you can see it's actually slow and it's there's delay. But here's one with using AI. Okay, so the thing about AI is, of course, that training is we do offline, and then that takes time and bandwidth. But once the system is trained, actually doing the processing during the surgery is real time. It's very high, and the bandwidth is very low. Okay. So we can operate, so this is operating 20 hertz, but in fact, we can actually operate up to 50 hertz. But it's not needed because, we don't need to update the robotic arm control that precise, that fast. Okay. So that was a structured light imaging, but as Hyun-Chul mentioned earlier, we also developed what's called optical coherence tomography system for providing 4D image. So OCT is a high resolution imaging system. So typically, XYZ size is like 1024 pixel by 1024 by 1024 pixel. Okay. So basically that's just 1 billion basically of pixels. And then if you want to be real time, that's at least 100 hertz and then 12 bits. So that's actually where the hundreds of gigahertz bits per second comes from. Okay. So there's a tremendous amount of data. And what we want to do is actually not requiring such a high density scan, because by utilizing like a diffusion AI, some form of a generative AI, we can actually sparsely scan OCT and then fill the gap very precisely using various type of neural networks we develop to go. In fact, we can actually go into super resolution type of 4D imaging to guide surgical robots. So as I said, I won't go into the details, but this is some example of neural architecture that we developed that has a multi-residue to reduce the speed, to reduce the error, and also the converges much faster. Okay. So this is like a quick example. So this is a fish, eye imaging. Here's a fish. You see a picture of a fish. I don't know whether you can see my cursor. Okay. And if you try to do high resolution a scanning, there's actually, because of the motion, and you see this motion artifact, and then you get this hugely distorted image. But now, if you use a sparse scanning and then combine with a neural network, and then you could see a lot of this motion artifact has been eliminated, and you can actually get a high resolution. And this is actually so this fish eye is moving a lot faster than the human eye, but this is enough to be able to guide our robot for, say, cornea transplant surgery. But so let's actually go back to our star robot. Um, so at the end of the day, what we want to do is that with the star robot is using the structured light image, get what we call point cloud, as I said. So it's basically a 3D image, but with all this proper distance laid out, so robot knows exactly where it needs to go to be able to. And once you have that, and then you can actually use the same artificial network to identify the key, like a reference points, and then identify where we need to produce where the plan the sutures. So that's actually what you see. So you see, oh, so 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 this is intestines. The two lumen of the intestines actually combine so together like this. So we need to suture this line across here and then fold it and then suture the outside. But anyway, and so we can provide all that imaging and then basically this artificial node using AI. Okay. So that's so and even though the tissues are moving, okay, so we can actually track those nodes very precisely because that becomes a reference point as to where we need to suture. Okay. But not only that, using OCT, we can also provide information about whether you have the correct tissue or not, and also assess the thickness of tissue. So here's a OCT, 3D OCT image of tissue that has a muscle and fat boundaries. So you could see, you could clearly delineate the different tissue, differentiate different tissue types. So the fat is yellow, muscle is red, and fascia is noted in blue. Okay. And so it could actually provide multiple informations about purely 3D imaging, high-speed real-time 3D imaging. It could actually provide, segment, artificial points for like visual markers. It could classify it into a different tissue type, measure the thickness, and then provide all the necessary information for a proper suturing. And then so it could provide what is a right bite size, and so this I already mentioned about tissue thickness, and also you could identify where the vessels are because you don't want you want to avoid suturing through the vessels, right? And then provide information about where is a safe area for a suture, and then you could actually provide these artificial marker planning points. So these are the points that where you're going to initiate suturing. Okay, so we actually did the testing. So this is a phantom testing. So this first column is that's a laparoscopic surgery. So that's a manual surgery. And then the middle column is a robotic assisted surgery. So this is using Da Vinci robot. And then the third one is a star robot. So the part that was suture is the center line here. Okay. And so we suture this inner and then outer. Okay. So this is when the sutures are completed. Okay. And then what we did is we did a flow test. So if you actually look at the flow through this sutured phantom, and then you see there is some turbulence for both laparoscopic and robotic assisted surgery. Whereas if you look at a star, it's actually very smooth, near laminate flow. Okay, so which means that the reason that we get this is because the suture spacing and then also tension is consistent. That's what it implies. Okay. And then, encouraged by that result, what we did was we actually did a pig surgery. Here's actually a live pig. Here you see the stomach and you see the 2 feet here. And then again, you see two robotic arm, one for suturing, another one for providing imaging and sensing. Okay, so this is a view inside. Okay, so that's the intestine being prepped. Okay, and so this is actually a picture of suturing, being performed, and it's kind of slow. I don't know, it's stuck. But anyway, so let me just go. So after, so we did so we did a four surgeries, and then we had one control, and if you look at the weight at surgery compared to weight after sacrifice, I think we waited about a month or 2 months, and then you see that that two of the pigs actually they gain weight. Other two, there was slight weight loss, but not very significant. And then also in terms of leak pressure, it's actually pretty good, strong. And then lumen potency is also very good. They're all above 80%. Okay. And so and of course all four survived the surgery. Yeah. So I guess one more thing that I want to say about this is that there's a certain part of the procedure that was actually done manually, actually. And then what we are trying to do is actually now I trying to make it more fully autonomous, but also, not only just certain procedure, but we want to utilize more of physical AI to control the overall movement of the robots and also the procedures itself. Okay. Um, but also, I would like to also bring up some smaller microsurgical robots. And 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 there are many different types of microsurgical procedures are done in neurosurgery, cardiovascular, eye, ear, nose, and throat. So there are many applications, and and using a similar technology, um, um, but operating on like a say handheld type of a format, we could build some what we call a smart surgical tools that go beyond the limit of a human fine motor control. So let me skip this. So this actually has an OCT sensor. And so this is a quick demo. So imagine this is a needle, and then you wanna, for example, have a safety barrier. In fact, so you want to go very close to the surface, but say you don't want to touch it. Okay. So you have a little sensor. So it's almost like a collision avoidance type of deal here. Okay, so there is a fiber optic sensor, and then there's a laser beam that comes out. It actually measures the distance very accurate. In fact, the accuracy of a distal this sensor is about a micron. So so it's kind of overkill. But so this hand is actually pushing it down, trying to touch it. And what you see is a motor based on the sensor. It knows that it's going to touch it, and it actually pulls back. So the tip is kind of flooring, but you could see if you look at the back part, the motor is actually compensating for this hand movement. So let's see if you can see it. Okay. So let me skip that. So that's good. So what do you use this for? One thing that you could use it for actually very precision, injection. There, like in ophthalmology, there's a procedure called subretinal injection that you're required to deliver drug very precisely in certain layers. But if you're trying to inject something, freehand, there are a lot of issues. In fact, what happens is you're trying to inject, but of course your hand drifts. So you're not going to deliver drug in the layer that you hope to, and then there's this drift. Okay, so this is actually a hand motion during the injection. There's injection one, two, three, four. Okay, and then if you look at the during the injection, ones that you think is actually very precise, there's actually a lot of hand tremor that goes with it. So for this one, average variation, this one was actually very good, about only 25 micron. And he said, that's great, perfect. But in like subretinal injection, you actually have to be able to, be able to inject something with a less than 510 micron type of a resolution. So that's not good. So, so we could actually use the same type of sensor. And so if you look at the tip here, the tip is actually, once it goes into right depths, it's, you see how stable this tip is. Yeah, so it, right? Because this sensor has a resolution that's less than 4 microns. And then this sensor is actually pretty fast. So it actually controls the motor at thousands of kilohertz. So it's actually compensating at real time. Um, so if you look at this, basically, if you track the tip of the injection needle, you see it goes in there. Once it actually sees where the target depth is, it actually it automatically goes to depths and then locks it during the injection. And then it pulls back, goes in, locks, and repeats. So this is actually actual retina. So we're actually doing a subretinal injection here. So there's no XY control. The only thing that we're controlling is the depth. Okay. So it's hard to see the needle because needle is only like 35 gauge, which is like 100 micron. And you, and then it seems very superficial, but it kind of is because human retina is only about 350 micron, and then we are only going in about 250 micron from the surface, which is, well, surface of the inner surface of the retina, which is what we call ILM layer. And so if you compare like just a manual injection versus basically this OCT sensor guided, and you see how precise it is compared to a manual guidance. So this clearly shows that, by using, the the optical sensor and then also AI, it basically gives you a better result. Okay. So this is a similar things, but you can utilize similar technology, but integrate it into a forceps to be able to grasp. One of the things with the problem with the forceps for microsurgical procedures is as you open and close, there's actually a lot of up and down motion. But by using the type of imaging sensor and a control, you can actually eliminate all this unwanted motions and then allows actually very precise grasping of the tissue. So this is a quick video that demonstrates this. So without compensation, so here's actually 100 micron of fiber here, kind of transparent fiber, and you're trying to grab it. So this is a manual one, and then you'll so typically you struggle it, and I don't know if you notice it, but it actually touches this surface, and that's usually not a good thing. But by using our technology, we can actually avoid a surface. Once you start to work, you can see here the motor operating, right? And then create a right offset, and then you can grab it without touching the surface and damaging it. Okay, and this next video just shows that we can actually do that in water. Let me skip all that. Oh, yeah. So these just summarize the results that we could actually perform those type of procedures much better. Okay. Another one that I want to just show you, I think it's a last surgical procedure that I want to mention is cornea transplant surgery. So, and corneal opacities are leading cause of blindness, and it accounts for about 2 million new cases worldwide. And in United States, it's about 50,000 cases per year, and there are many people actually waiting for procedures, but there's just not enough donor cornea that's available. Okay. And so, but there are different types of a cornea transplant surgery. There's what they call penetrating keratoplasty, which is what also called full thickness keratoplasty, which is removing the full thickness of the cornea. But the problem with that is the rejection rate is actually very high. And so about 18.5% requires repeated cornea transplant procedures. And as I said, just mentioned, there's not enough cornea, so you don't want to utilize, multiple cornea for a single person. Okay. There's another procedure that's not commonly performed. It's called deep anterior laminar keratoplasty. Okay, so which actually remove all the most stromal layer from the cornea, leave what's called a Descemet's membrane and endothelium layer, and then put a donor on top of it. Okay, and by doing that, you don't actually penetrate into intraocular space or anterior chamber. It's all done external. And because of also that, the infection rate is low, and then rejection rate is extremely low, and then you have much higher success. But the reason that they don't do this procedure is actually it's a very difficult procedure to perform, because if you think of the human cornea is about, say, 500 micron thickness, right? And then Descemet's and then endothelium layer is only maybe about 30 to 50 microns. There's actually what they call Dua's layer, which is a high density stromal layer. You actually want a little bit of that as well. So you're removing 450 micron and you're leaving 50 micron. So you have to actually be able to separate those two layers very precisely, and which is a very difficult. And a lot of times they make a mistake and perforate the full thickness cornea. Then you just then convert doubt to PK. That's what typically happens. So we wanted to develop a surgical small robot that perform these doubt procedures. Okay. So this is actually a small robot that we developed. It actually has two motors, which is essentially a needle drive. Okay, so it actually rotates and pushes the needle forward. It has a sensor in there, and it also has an imaging system in there to be able to guide into a proper thickness. Okay. So here's a cornea, and then this is actually what the sensor sees. Okay, so but also we have an imaging system that also sees the 3D as well. Okay, but it actually sees exactly where the Descemet's membrane is, and it also sees how far is a needle tip relative to Descemet's membrane. Okay, and so what it does is actually, so it has a neural network, so it's a fully autonomous. So when we turn the power on, basically turn it on, it actually sees all those different layers, know where the different tissues, know where the Descemet's membrane is, where the needle tip is, and it just automatically drives until it gets the right depth, and then it actually injects bubble, and then it either hydro dissect or numero dissect that layer. Okay. So this is after you inject air to numero dissect. So this part, it gets ugly. Becomes, it's what they call a stromal blanching occurs because of the air pressure. Okay, but by doing that, actually, what happens is you actually push the Descemet's membrane downwards, creating this big bubble, and then you see this very clean separation of the Descemet's membrane from the stromal layer. So we perform a bunch of uh, the rapid surgeries. So we compare, teleoperated mode, basically the surgeon, doing the needle depth control versus autonomous robot. So it's a fully autonomous control. And we actually performed two separate cases, separate by, I think it was about 6 months. So we did the initial testing, and we actually So I should also mention, so we did a teleoperation. We had all the imaging data, and then and plus we some of the phantom data we did, and then we actually used those to train our very first network. And after what we did was we use that network and training data, train network to do the first AR1 autonomous mode one. And then later, once we had the result, we actually use that data plus all this other data to train the updated a neural network and then perform the second procedure. Okay. So this is kind of comparison. So in terms of needle depths, penetration depths, and then completion time, you could see if you just do manually, the dispersion is, large. Okay. And then the 100 micron, it was basically essentially our target depth. That was actually our safe target depth. And then you could see some consistent error in AR1, and then but although it's much improved compared to manual cases, but as we include additional data from the AR1, and you could see the improvement in AR2 in terms of needle depths, penetration depths, and also completion time. Okay, so we're doing additional studies. So this is actually not, we don't think this is an optimum. I think we can do a lot better. But just, but it's actually roughly, in terms of overall number of eyes that we used, I mean, it's only about 50 eyeballs. And then which is I mean it's a really I would have to say bare minimum, but we don't want to keep sacrificing rabbits for so we actually now trying to incorporate synthetic data, so we can actually generating artificial data from the using computers. And then we are starting to incorporate that to actually increase the diversity of the data to improve the accuracy of the procedures. Okay. So maybe I'm a little early, but so I like to summarize by saying that photonic image guided autonomous surgical robot tools and robotics have the potential to complete surgical tasks with more accuracy and precision than human operators. But I would like to add, the human surgeons is going to be always part of it, of surgical procedures. Now they play different roles, and they need different types of expertise in operating this type of robot and oversees this type of procedures. And accurate tissue tracking, event detection algorithm, novel control strategy enables autonomous surgery in soft tissues. If you look at the development of AI, actually a lot of work on AI actually has been done on in terms of image post process, but um, but now, I mean, you see more and more of, what we call physical AI, right? Using basically AI to control the systems, and right now we are actually using AI as a partial enabling technology in different aspect that goes with a different, optical technology. But, we actually see what we foresee is kind of more about overall capability in using AI to control every aspect, for more of a physical AI approach to a surgical robot. Okay. And then, so anyway, so we need more clinical testing, but in order to do that, we need more technical improvements. We're still working on improving our imaging and sensor integrations, optimizing surgical planning and control, and then also improving surgical user interface is also a key thing because we need to provide right information. So if something goes wrong, we want to make sure that we provide right information to the surgeon so they can press that red stop button if needed. Okay. So, so I like to thank, all the, you know, um, all my actually students and postdocs, and then also collaborators. Nice thing about Hopkins is that we have opportunity to work with, various different type of, surgeons. So, over the years, I've been very lucky to work with, you know, I mean, talented surgeons, like Jim Handa, and then Peter Galbach, and then John DeParco, and then Wade, and Gerard, and Robert, Betty, and George, and so on and so forth. But also, I'd like to mention that I don't build robots, so the robotic part of all the smart microsurgical robot or surgical tools, those things I could do. But the bigger robots, those UR robots and Da Vinci robots, those are the Axel Krieger's lab. So these are people from the Axel's lab. And then also, of course, all the funding agency. I have to thank them because without money, I cannot do anything. So anyway, thank you. So I'll be happy to answer any questions if you have.